Hello, hello. All right, this is Dr. Brown. This is a special midnight edition. I am not commuting right now, fortunately. It is just about midnight, and I drank a lot of milk tea, and now I can't sleep. So I'm going to record a podcast episode. So I want to talk about clinical reasoning styles. Basically, what is the process we use to come up with a diagnosis? When you're faced with some initial data, such as a chief complaint or some other clinical problem, how do we kind of reason our way to the underlying explanation of the problem of the data? So there's actually several different approaches for how physicians do this, and I'm going to talk about that now. I did want to briefly mention that before you get into the weeds of trying to figure out a diagnosis, you should probably use the sick or not sick approach, which is basically a quick determination of, is this really acute? Is this patient really sick? Or do we have some time to sort of figure this out? Like if a patient comes to the emergency room and they're complaining of chest pain, do they look like they're having a heart attack like right now and you need to like do something about it? Or do we have some time to really suss it out? Same in psychiatry if someone's presenting with suicidal thoughts or something like that. Are these more of a passive death wish or are they gonna run out of the office and try to hurt themselves like right now? So that's the sick or not sick kind of quick heuristic. So, assuming you've done that and we've got some time, first approach I'm going to talk about is called inductive reasoning, also called the bottom-up approach. And this begins with gathering comprehensive data. So, history, symptoms, tests, and you're going to try to synthesize all that information at the end to arrive at the diagnosis. So you're gonna collect all this data, you're gonna try to remember it and look for patterns and try to figure out what's the best explanation for all this data that you collected. So this approach is the approach that's primarily used by early trainees. So I don't mean early trainees are the ones who only use it. I just mean early trainees primarily use this approach. Okay. More experienced clinicians, as I'll talk about more later, also use this approach, but only typically when other reasoning approaches have failed or are likely to fail. So, as a very brief sort of mini example, let's say you have a patient that you are seeing for the first time in the outpatient psychiatry setting, and they have a chief complaint of my mood has been very low lately. Okay. So in this case, if you're using inductive reasoning, you're going to conduct a very thorough systematic assessment, including a psychiatric history, review systems, physical and mental status examinations, maybe get some collateral, et cetera, et cetera. Let's just say that a detailed history reveals depressive symptoms, significant weight loss, disrupted sleep patterns, and this has occurred over several months, and they've got no history of mania or psychosis and no significant medical issues. So at the end of all that, you kind of synthesize the data and come to a diagnosis of major depressive disorder being the diagnosis that best explains all of the data that you accumulated. Okay. So moving on to deductive reasoning, also called the top-down approach. This is where you use your clinical knowledge and theoretical frameworks to generate a set of plausible hypotheses, which is also called a differential diagnosis, that could explain the presenting problem. And then, once you have this list of plausible hypotheses, they can be reorganized. In other words, some can be ruled in or ruled out by targeted questioning and examination. So, as another mini example, let's say if you have another outpatient, a patient who presents with the chief complaint of, I feel anxious all the time, right? So, starting with the broad symptom of anxiety, the physician using deductive reasoning would say, what what are the diagnoses or explanations that could cause anxiety as the chief problem? Well, that could include generalized anxiety disorder, adjustment disorder, depression with anxious features, acute stress disorder or PTSD, panic disorder, maybe mania, maybe psychosis, substances can cause anxiety, and some medical conditions like thyroid dysfunction. So you do some focused questioning based on your list of plausible hypotheses, your differential diagnosis, trying to rule in and rule out things, or in other words, re-rank things on that list to increase the probabilities of certain things or find out that others have much lower probabilities. Your questioning reveals a history of pervasive worry about various life circumstances, but no panic attacks, no substance use, no depression, no manic symptoms, no psychosis, and normal lab studies, including thyroid function tests. So, given that you've kind of ruled everything else out or made them much less likely, rather, that leads you to a diagnosis of GAD, generalized anxiety disorder. All right. So that's deductive reasoning. And then the last approach that I'm going to talk about, I simply call pattern matching. This is basically where an experienced clinician recognizes a presentation based on their accumulated experience seeing, hundreds or thousands of patients. So this is where a patient's presentation matches a known clinical pattern or illness script, as it's sometimes called, from the clinician's experience. And that allows them to rapidly identify what the most likely culprit is, what the most likely diagnosis is. All right. So, as another mini example, a patient presents to you with a complaint of, I'm hearing voices telling me I'm worthless. All right. So the more experienced clinician immediately identifies the presentation as suggestive of a psychotic disorder, most likely schizophrenia, based on the presence of auditory hallucinations with derogatory content, which is a common pattern in schizophrenia, and the fact that the patient is a 19-year-old male, which matches the common demographic pattern for schizophrenia. And this recognition guides further assessment for other symptoms of schizophrenia and consideration of the patient's functional status and history to further support the diagnosis. But even though you think that's the most likely diagnosis, based on you pattern matching on the overall gestalt of the case, the illness script, you don't want to prematurely close on a single diagnosis. So to avoid that, you should still consider a broad differential diagnosis, especially don't miss diagnoses like substance use or medical causes, because that would be a very different treatment in those cases. All right. So, each of these has their pros and cons. Pattern matching is the most efficient, but it takes a while to get there, right? You have to be very experienced and see a lot of normal and a lot of abnormal to be able to differentiate between, the hundreds of possible diagnoses. Deductive reasoning is also pretty efficient when you are able to come up with a thorough set of plausible hypotheses, a good differential diagnosis, especially those don't miss diagnoses. And then inductive reasoning is the least efficient, but potentially you're the least likely to miss something, right? Now, an experienced clinician is going to use all of these at different points. If an experienced clinician is unable to pattern match on something, then they might drop down to deductive reasoning. Or if the presentation is very unusual or atypical, they may struggle to come up with what feels like an adequate differential diagnosis. And so they might drop down to inductive reasoning and just collect a lot of data and try to piece it together at the end. All right. So, as a non psychiatry example, let's say a 19-year-old with no past medical history presents to the emergency department with sudden onset right sided chest pain with shortness of breath and a sense of impending doom, but they have normal vital signs. The emergency room physician will likely pattern match this to be a panic attack. That's their kind of gestalt, most likely diagnosis. But they're also going to generate a set of don't miss diagnoses, such as pulmonary embolism, acute coronary syndrome, maybe Boerhaave syndrome. And they're going to do some targeted questioning and examination and maybe some lab tests to rule those out. Yeah, I think understanding and being aware of these different reasoning styles, the inductive, deductive, and pattern matching approaches can help with your diagnostic accuracy. Because if you know what you're doing, you're more likely to, be careful and be accurate and not miss something important. And sometimes, we're too eager to pattern match when we don't have enough clinical experience yet. And so we should consciously decide, this is not pattern matching for me. I want to jump to this conclusion, but I really haven't seen enough of this to be confident. Let me try to generate a much more thorough differential diagnosis. Or, I feel like it's schizophrenia, but, this just seems pretty atypical. Why don't I just collect a lot of data and try to figure this out at the end? All right. Well, I hope that was helpful. I'm gonna try to go to sleep as the Benadryl is hopefully kicking in now that I took a little while ago. And Happy New Year, everyone.